Good afternoon, everyone. Thanks for joining us. We'll just wait another moment or two to allow a few others to come in as well.
Douglas.
Well, I think we'll go ahead and start with the introductions because time always goes very quickly with these activities. My name is John Jenkins, as you'll have seen from the information, and it's my great pleasure to welcome you all to this webinar this afternoon. We've deliberately chosen what I think is quite a stimulating title. This is an issue in which the presenters all feel somewhat passionately. We believe that IPL or IPE has made enormous progress in recent years, and there are lots of people who have been very involved in that, many of whom are on this call this afternoon. But we believe that there's a sense in which it hasn't really got into the center yet, and it's still on the periphery. And we want to discuss with you some of the things that we believe might change that, and how we can see interprofessional learning, interprofessional education, interprofessional collaborative practice being seen as much more central and much more critical to the delivery of healthcare. So we've chosen a range of topics so that they will not all just repeat the same messages. We come from different perspectives, and we will try and develop this as we go through. We're going to have about 3 minutes at the end of each of the presentations for initial comments or questions for clarification. And then Derek Gallen is going to chair a longer panel discussion time at the end. So we'd encourage you to enter questions as you think of them into the chat function as we go along. It's very helpful then that we can start to consider those and then be ready to share those and have a chat together about those when we get to that stage of the afternoon. We've scheduled in a short 10-minute break after the third presentation also, just to give people a moment or two away from the screens. As usual with Zoom, I'm sure you're all more than familiar with it now, but it is good if you would just mute your mics while this is taking place so that the presenter can speak without any interruptions. Whether or not you want to have your cameras on is fine, although at the end during the discussion we would ask you if possible to switch your camera on if you're contributing directly to that conversation. So there's been quite a lot published on the need for greater collaboration across the spectrum of all those involved in the role of interprofessional education for the delivery of high quality and safe patient care. For example, in the US, the National Academies of Medicine in 2017, in a paper by Malcolm Cox and colleagues, I just quote one sentence from that report, where they said the overall and joint goal of the educational, delivery and regulatory systems is collaboration among and across the health professions and health delivery systems, as reflected in the various accreditation standards and processes. And we know that in the North American context, quite a lot of development has taken place in order to improve that collaboration and the communication between those different elements. Part of our group this afternoon presented a paper to the General Medical Council in the UK a few months ago, giving an overview of the literature regarding the way in which regulators can help in this process, as well as educators. And we ended up asking the question, and I think it's a relevant question for our discussion this afternoon. We asked the question, what is the need or potential for interagency working between regulators and education organizations to provide a joined-up system for multi-professional recognition of those involved in training of healthcare professionals? So perhaps we can just leave that hanging as something which is worth considering, because we haven't had an answer to that question. And we've challenged certainly the medical regulator in the UK about the importance of recognizing that there's a need for this to be developed further. We will hear this afternoon about how other parts of the UK regulatory system are already taking steps to address this. So that's all I want to say by way of introduction. I'm delighted to introduce Professor Olle Cate. You've seen in the paperwork his title and his enormous experience in this area. And of course, in particular, the Entrustable professional activities, which he first identified, but which have an important role to play in the area that we're discussing today. But it's important that we define what that role is and not try and force them in as square pegs into round holes. So I'm delighted to hand over now to you, Olle. Thank you.
Thank you very much. Let me share my screen. Can you all see my screen this way? I'll start the presentation. Here we go. You see my first slides, John? Yes? Okay, perfect.
Yes.
So I toned down the title, what was a little more provocative when I started, but how do interprofessional objectives fit with the idea of EPAs or the EPA's curriculum? And I only have 15 minutes, so I'd like to refer you to a publication in the journal Advances in Health Science Education that we elaborated that topic also a little bit. So for those who are less familiar, let me just give 3 slides on EPAs and define that. So entrustable professional activities are units of professional practice. You can think of them as tasks to be done that may be entrusted to a learner to execute unsupervised once he or she has demonstrated their acquired competence. It has been a dominant component of competency-based medical education in many countries in the world. So it includes 3 words: entrustable professional activities. So entrustable means that there are acts that require trust by colleagues, by patients, and by the public. They are professional, so they are confined to occupations with an extraordinary qualification and right, such as in healthcare. It could be in other domains, but we're talking, of course, about healthcare. And they are really activities. So there's tasks that must be done, and it's not really competencies. I'll come back to that in the next slide. It's so funny that everybody who enters the room rings the doorbell. I would suggest, why don't we open the door and people can just walk in? That's the funny sound that you hear now. But anyway, so EPAs ground competencies in daily practice. That's actually what their role is. So this slide, I really like to explain this slide because there is, in practical use, competencies and EPAs are sometimes used as if they were alternatives to each other, which is not the case. And they are conceptually completely different. So competencies describe persons. Anyone, as we are in the audience here, everybody has their own competence, knowledge, skills, attitudes, and values. And those are invisible if you don't see somebody do something or execute a task. It's really the ability, as the Oxford Dictionary says, the ability to do something successfully or efficiently, whereas EPAs are not descriptors of persons, but descriptors of work. It is a way, an arrangement of the work that must be done, essential units of professional practice, we call them sometimes, such as discharging a patient, counseling a patient, or a treatment plan must be created, or a central line must be inserted, a patient must be resuscitated. So where the Oxford Dictionary says the ability to do something is a competency, that something, actually, that is the EPA. That is the thing that must be trusted to be done successfully, efficiently. And there is permission required for that qualification. So if you are qualified to do that, that's because you have the permission to do that. If you build a program with EPAs, you can see that there's 2 dimensions. So there are different sorts of competencies, and you could say interprofessional collaboration or communication could be one of such competencies, and you're competent or not so competent to do that. And at the end of the day, somebody would like to know whether you are you have acquired your competencies. But EPAs actually show that in practice. If you have to do something where interprofessional collaboration is important, then it's one of the competencies that is required to be able to trust you to do EPA 1 or 2 or 3 or 4 or 5, whatever. So the recommendation is using EPAs to focus the assessment and using competencies to provide feedback to learners. So to just give an answer to the question, is interprofessional collaboration can be that conceived as an EPA? The answer is actually no, it cannot. Because again, EPAs are activities, they are not the behavior, they're not personality traits. They must have an identifiable beginning and an end. They should be suitable for entrustment. There must be a phase of prohibition to enact that EPA, followed by a phase of permission to act. And those are separated by a grounded decision. So first you're not allowed to do that, then there's a decision, and then you are allowed to do that. So just imagine, can you prohibit a person to do some interprofessional collaboration, even if you're on the very first day of your rotation or whatever? Can you imagine there could be a certification or qualification credentialing for interprofessional collaboration? Can one schedule a trainee to do that? Like you would say, do this operation or admit that patient or make a discharge summary. Could you say, now go ahead and do interprofessional collaboration tomorrow morning? It's scheduled at 11 o'clock. That's not really what it is, right? So, and then also, if you would translate interprofessional collaboration into an EPA, are you suggesting that other EPAs do not involve interprofessional collaboration? So interprofessional collaboration, of course, is hugely important. Much of healthcare really depends on interprofessional collaboration, and many specific focused tasks or EPAs with clear beginning and an end can be considered interprofessional. So interprofession is a component of those EPAs. If you would have running a ward round or doing emergency teamwork, surgical procedural teamwork, multidisciplinary meetings, morning reports, patients handover, discharge planning, execution, interprofessional consultations with a team or to ask or provide that, all those elements all are impossible without interprofessional collaboration. So what you could rather say is that interprofessional skills are conditional for entrustment of many EPAs. So just imagine what an EPA actually looks like. So this is a framework that we use to describe a full EPA with a title, specification, potential risk, and in case of failure. Just imagine you are going to describe conducting benign gastrointestinal surgeries as something that a surgeon is allowed to do somewhere in the course of their training. Of course, in the specifications, you would have to say, well, one condition before we would trust you to do that is you could work with a team in an operation room, anesthetists, scrub nurses, other people. There's potential risks in case of failure. If you cannot collaborate and communicate with these people, there's more risks that the operation will fail. In your relevant domains of competence, things that we are going to watch when we observe you and see whether you are ready for unsupervised practice for this, one of the components will be interprofessional collaboration. Of course, you have required knowledge, skills, attitudes, and experiences. We'll have to train you in doing that, actually. So it's all important for that EPA. Information sources to assess progress and support summative entrustment decision. We might ask other people than your medical colleagues whether they think you are ready to work unsupervised, because they will have to work with them. So we can include that also in the description of the EPA. So if you think of it, even conducting benign GI surgeries, the word interprofessional doesn't occur in that title, but basically it's impossible to do that without interprofessional collaboration. So again, if you think of entrustment decisions, we have 5 levels. This is one EPA, and levels of supervision that we distinguish are being present, practice the EPA with proactive supervision. Level 3 would be practice it without direct supervision, so with indirect supervision, reactive supervision. And then at level 4 would be unsupervised practice allowed. This does not mean that you're working alone. Of course, you're working in a team, and much of what we actually do, supervised and unsupervised, doesn't mean you're working independently on yourself. But it is actually that summative entrustment decision includes that you can work in a team too. After a number of observations for ad hoc decisions, there is a summative entrustment decision that would include our confidence in all the aspects of that EPA before we would trust you to do this without educational supervision. So what does it take to make an entrustment decision? And I want to show you this because I think it has a connection with interprofessional collaboration. We did a literature review and came to 5 big groups of factors that are important before entrustment decisions are made, what people weigh in entrustment decisions. It's capability, specific capability, knowledge, skills, experience, awareness. It's integrity, being truthful, good intentions, benevolent, patient-centered, being reliable, conscientious, predictable, accountable, responsible, showing humility, observing limits, your own limitations, willing to ask for help, being open and receptive to feedback, and agency. Now, if you think of this whole set of 5 groups of important factors, humility is something to realize, because here's where interprofessional collaboration could be very important. If you disentangle that and think, what is actually humility? It is the willingness to admit your own limitations, the willingness to ask for help and advice when needed, being receptive to feedback, and recognizing relevant or sometimes even superior ideas and knowledge and skills from other people, including interprofessional colleagues. And that domain is so important to be trustworthy, to do the things in healthcare, that I think that in that humility domain is where interprofessional collaboration is a key element. So now, finally, so why is the road to IPE so hard and so long? So I think it's, on one hand, it's practical issues. If we think of interprofessional collaboration and education, that's what we start doing in our schools, but it requires a lot of scheduling to align objectives of different programs, and there is practical barriers, but likely those barriers may not be the most important ones if you can organize that well. There are also other things, and I think we should not shy away of thinking of how can we solve those other issues, and those are in many respects identity issues. So social identity theory explains that people have strong professional identity formation, that if that's what we try to promote in our learners, but that they force to identify foremost with one professional group. Of course, if you're being trained as a nurse, of course you want to get that identity of a nurse. A physician would be medical, or in a subgroup like a medical specialty or a specialized nurse, being an ICU nurse. We see them on TV every day, and they have their professional identity. So identity preserves pride and self-respect. It's important for individuals to have that, to foster motivation and drive. But it also increases a little bit of in-group favoritism and out-group derogation. Those are terminologies from social identity theory. And there's a natural stance, and we have to teach learners to resist that in interprofessional collaboration is to favor your own opinion or from your own professional group over others. So if you just think of, you're a medical professional, that's your domain and that's your group, you're identify that, or you're a surgeon, that's a subgroup, or you could be an interprofessional surgical theater team with other people outside your profession, or a ward team with others outside your professional, or with researchers, you're a surgical researcher, partly outside that team, or the National Surgical Association, and that's not your local team, but it's also a geographically different team, or medical education team, maybe with educational scientists. There's a nursing profession. Of course, they have to connect to each other. There's educators. There's family members. That's even a different. So which groups or which teams and which identity prevails at which moment? Which groups do you feel most at home with? So professionals really need to learn to navigate potential tensions between these different groups. And it will be interesting to think of how we actually educate learners to do this well. So in conclusion, interprofessional collaboration cannot easily be captured in one APA, pervades many APAs in healthcare, can be on the wish list for many curricula and institutions. It has been on those lists for many years, for maybe even too many years. And we really need to make steps now to see what we can do on those barriers, not only practical, but foremost cultural barriers. And social identity theory is openness to other professionals. Showing humility requires learning to navigate those tensions of professional identity formation. And I just added one slide to make you aware, if you're interested in APAs more specifically, just think of signing up for one of our courses online or vis-a-vis. Thank you very much. And I didn't observe the time exactly, but I think we have a few minutes. I'll stop sharing my screen before we go to the next speaker. Is there any questions that you would like? Just one or two questions I think there's space for. Would like to add. Julie Browning, are you clapping or is that a hand for a question?
I was indeed applauding, Olle, but I just wanted to thank you for that talk. And yes, I'm really struck by what you said about those the quality of humility in interprofessional education and in education in general. Where does that come from? Where did you spot that? I mean, what you've suggested is that social identity theory, in some degree, produces pride, whereas what's required for interprofessional education is humility. What would you say are the inferences of that for healthcare education in general?
Yeah, so it's funny. Then we looked at different studies, and I was involved in a number of those studies. We basically asked the question of from clinicians. So here's a critical task: what would it take to entrust this task to a learner? So what are the most important features you would want to see in the learner? And usually we did like nominal group techniques and other techniques, interviewing, and usually have a long list. But interestingly, very high on the list that people would say, we expect the learners to show their own limitations and to be open for feedback. So even if they have higher level skills, we may not trust them if they don't acknowledge that they sometimes need help, and they run into limitations. And funny enough, on those lists, it's pretty high on those lists where we find them. So I think if you connect that with collaboration with other people, also interprofessional collaboration, that falls into that same bucket of humility, of being open and ready to think that there might be other people who can teach you things that can help you where you have your limitations. So that's what many educators at least find important before they make an entrustment decision.
Olle, I'm struggling a bit with my stuff, as you know. Can you hear me?
Yes, yes.
Yeah, good, because we have got a question in the chat section, which is, can interprofessional education be a force to develop the multi-professional team, or do you need a well-functioning multi-professional team first?
Are you still there, Dirk?
Yeah,
oh,
I hope so.
So can you repeat the question? Was it a question?
Yeah, can IP education be a force to develop the multi-professional team, or do you need a functioning multi-professional team first?
Yeah, so I think there are different approaches in education that you could do that, but you need to force it. But I would actually say forcing sounds like something that that is actually difficult and that may lead to resistance. But what I think the conversation with learners, and one of the most difficult conversations, is about humility, because our natural way of thinking about education and development, also for learners, if the better they show, the higher they will be valued. And in some cultures, even, it's very difficult to admit if you have not done something right. At the same time, we have to get used to showing to learners that they are in a situation that they are not perfect. They can always improve. And if they never admit their limitations or not being open to other people, we might have more difficulty trust them to do critical work in healthcare if they realize that they might be more open to actually do this. This is on a very, I would say, conceptual or psychological level, but I think that conversation with learners is so important, because implicitly our message is very often, the better you are, the higher you score. So don't show any weaknesses or limitations, because that might not count towards our picture of you. But if you talk about humility, it's actually, there's a component that's actually almost the opposite. If you never show your limitations, we start wondering whether you actually can deal with your own limitations and will be open to other people. So I think it is a conversation that I think we have to start doing with our learners too. And you made a call that forcing, but I think it is a natural way of learning to work with other people.
Thank you.
And I'm not really sure. I was supposed to observe the time, but I think we are ready for the next presentation by Liz Anderson from the CAIPE institution. So Liz, will you take over from me?
Will do, Olle. So thank you very much for the invitation to come and talk to you from the UK Centre for the Advancement of Interprofessional Education. And indeed, Esther, your question, yes, there are lots of papers where people have gone into multidisciplinary teams and been able to take them from whatever place they start into a better functioning team and evidence of improving outcomes. And Olle has set the afternoon off to a really good start, talking about some of the complexity that there is in this field of the traits that we're seeking to have to improve patient outcomes. Many of you will be CAIPE members. You're probably here as members because of your institution and organisation. And I hope that you will recognise these 4 areas of the work of CAIPE as I go through them this afternoon with you. So scholarship, informing policy, supporting those that are trying to deliver interprofessional education, and being a global partner with others around the world. And I'm going to pick up on each of these as I go through my 10 minutes, but remind you that CAIPE is a charity. It's a membership organisation. We welcome our members. We are highly indebted to the support we've had from many universities over the years who have sent their scholars to work with us and with whom we continue to develop our thinking and to push forwards. It is a member organisation for support in an area that has been challenging, and we have our working groups. We respond to all the initiatives that come our way and seek funding. So let's just go through our story, set up following the incredible work of John Horder, himself a GP. He was, of course, the chair of the Royal Society of General Practice, who recognised the need to be together, to learn from each other. And in his time, in 1987, CAIPE was established, and the world-renowned definition came from the debate and discussion of academics here in this country. And then over the period from 1997 to 2012, the Tony Blair years at the beginning there, a lot of money was pumped into thinking for just a little while. During that time, Hugh Barr was chair, followed by several by Jeff Meads, but Hugh was prolific in using this opportunity to publish, to work with the Department of Health. And the Blackwell Wiley book series, which I would commend you to go and look at. The journal was launched in association with CAIPE. The Altogether Better Health conference series, which we would welcome you all to, began and came to London in 2006. And it was last here in 2016. So at this point, the website was started, the professional bodies started to come on board. And I do remember these were my early days 20 years ago, working with CAIPE, going to the Houses of Lords and Parliament and lobbying for a new think of approach to the way in which we do professional education to bring our students together a little more often. You'll see on the left, the triangle showing the growth, and from 2012 onwards, several chairs, but sadly less money has come our way, mostly because it's gone into areas such as patient safety. Not a bad thing, of course, but following through some of the early work has become very difficult to do. So here is the definitions, world renowned. We're talking about learning with, from and about each other to improve the quality of care. And in fact, when the World Health Organization got together to do its last definitive push for a real change, for a systemic thinking of what we're talking about, they could adopt the definition, but very little. And it remains underpinning of CAIPE's great achievements. And of course, we are charged, therefore, to make everyone workforce ready. And this document is about to be refreshed and updated. So just talking about scholarship, the Journal of Interprofessional Care sits here at King's University with Dr. Andreas, who is the editor-in-chief, and you will see the impact factor has gone up significantly, and the number of downloads has also increased. And here is the influence of this journal and its wide reach, being picked up obviously globally and receiving papers from all around the world. So what have we been doing in terms of scholarship? Well, very recently, talking with Health Education England about advanced clinical practice, what that means when you introduce a new role into the healthcare workforce, a little bit like putting a stone in the middle of a pond. This new role has to be assimilated within the working team, and we're looking at helping how that will happen, and have designed new workshops to help frontline practitioners come to terms with how they will function and revisit what team working means when we have new roles. So this handbook is being piloted at the moment and has been offered to several trusts actually around London who are thinking about what this means as we make team working more complex at this particular moment in our history here in the United Kingdom and globally. The Rutledge book series I can but commend to you. And I think CAIPE has commissioned lots of surveys of what's been going on and has looked itself into what has been going on in the United Kingdom. The last survey was 1997 to 2013, published in 2014. And about this time, there was at least 2/3 of all universities were pushing forward on interprofessional education and trying to ensure it was a seamless theme throughout their curriculum, and of course a growth in posts, academic posts, to push this forward. The preparation and publication of guides has continued. These guides tell us, from gleaning all of the evidence that there is, what is the best way, what are the theories that underpin it, how should you set up your interprofessional education, what will work well. And of course, we've had the best evidence medical education reviews. The last one finished in 2016. There are now 46 papers from those two combined, which show impact and influence. And the next edition of this best evidence medical education review is undergoing as we speak, with Andreas and Simon Cate from Canada. So these papers that come out of this show evidence of impact. They show evidence of how interprofessional education is changing not just attitudes, but behaviours and practice. I know this myself because I'm delighted that one of my own papers is in that best evidence review, based on work that we've done for over 20 years here in Leicester. But not to dwell too much on this, it's a theoretically informed piece of work of how to do work in practice with a real team, be they undergraduate or practice, and go through a cycle of change and reflection as you learn. And of course, there isn't a lot of time to go through these things in detail right now, but I'm happy to talk more about that at another time. And the CAIPE community has pushed the theoretical underpinnings of what we're doing. I think CAIPE has had many things thrown at it over the years. One of them is it's atheoretical and under-researched. Well, thanks to this BME review, it's certainly not atheoretical anymore. So informing policy, this has been the work of CAIPE for many years. CAIPE has got involved in the setting of standards and the pushing of professional bodies to continually reflect and think on what they're doing and what the outcomes they propel for their training, different professions. And certainly for one, in 2013, the General Medical Council was pushed by CAIPE to change its terminology to IPE must happen. And that was a pivotal moment for many medical schools. We continue to publish on principles and values. We do work with the interregulatory group, and we look forward to that going forward from this fantastic evening set up by the Association of Medical Educators. And we look forward to working with you as we go forward to think about what strengthening standards will mean as we progress. This is a moment in time. All of the different professions are regulated separately, and there is lots of thinking about what would we do right now if we were to start to train again. How would we connect our students across many of the domains, of which professionalism and patient safety are but two under which interprofessional education can take place. So we have recently worked with the NHS Leadership Institute, who have now begun to coin the phrase of collaborative leadership, that actually in the complexity of frontline modern practice, we lead together, stepping up and stepping back, needing that humility that Olle has just explained. And they were putting out papers, and we've been working with them on the need for interprofessional learning to develop your ability to be a good leader of the future. And in fact, I am now joint chair of CAIPE with Dr. Angela Lennox. That's a nurse and a doctor, and we hope to mirror and practice collaborative leadership. And on the 27th of October, over 10 presentations of universities keeping up with this, actually sharing their modules, both undergraduate and postgraduate, for developing leadership abilities interprofessionally was shared. And so we support interprofessional education in the UK, and I think a community of practice is what we are, where people come together often to lament that their efforts are not gaining the momentum they would like them to have. Staffordshire University held its corporate forum where our universities come together, share their work and what they're doing back in September 2021. And here's one of the operating department practitioner lecturers sharing the work that they're doing right now, which is pretty amazing. They've got a fabulous new simulation centre about to be opened, and are looking forward to doing more interprofessional simulations. And we go to Newcastle in March 2022. We set up workshops to promote and support the educators and people in frontline practice who wish to reflect and look again at what team working means, what is collaborative practice. And we think about all of the detail here. What does it mean to teach an interprofessional group? And how should I set it up? What should I do? What will good teaching look like? At the moment, some of us are writing a paper. In fact, I think Yubar may be with us in this meeting this evening, talking about the phases we've gone through in this country, from organic early visionary champions, some of whom got early money, moving through to strategic design of interprofessional education to come all the way through your curriculum, underpinned by the Dean's endorsement and by the endorsement of professional bodies, some of which was in this country underpinned by a great deal of funding in 2000 with the Common Learning bids, but sadly they died. I know myself the lament of having had a researcher for 3 years and wanting them to go on and follow the students through into practice, only to be told there was no more money to follow them through. The systemic phase is where we are now, and this is also part of the global vision, and we look forward to working with other organisations who are with us on this. This is a moment in time to think about systems change, both within practice and within how we teach. We can change all the standards we like, but we really must take practice with us if we're going to make anything meaningful in this space. And so many of us feel this is where we are. Finally, interprofessional.global. So through the United Kingdom, through CAIPE, if you remember with us, and many of you are, we take you to the broader group, the international group. So we work with all of the global leaders in all of the countries who, similarly to us, bring together communities of scholars to work together and connect. Interprofessional.global has its own website, and we're part of that. And we are looking at the next systems level policy changes and the next World Health Organization document. So I hope I have also stuck to my time, very conscious that I had quite a lot to say. Hard to summarize 60 years and where we are right now, but an incredible lot of energy and movement as we want to bring interprofessional education into the centre. CAIPE and scholarship go hand in hand. We look forward to further working with scholars in pushing this agenda forward. We really do need funders to fund the next steps. And we look to what this means for healthcare services moving to integrated care systems and the delivery that we can do in a different way as health and social care money is pooled. And we hope that there will be new opportunities here. And we welcome the opportunity for further collaboration. So that's a whistle-stop tour through what is CAIPE. I hope that's been helpful and informative, and I'm very happy to take some questions if anyone would like to ask.
Liz, we'll maybe just pick up one if someone has it, because we do need to move on.
So just looking there in the chat John. There were a couple, I think are slightly related, if you can hear me.
Yes.
I can see about patients. Yes, CAIPE has patients involved, and I think patients are central to what we're talking about. There's a fabulous paper that came out when the interprofessional movement in the UK started called "Don't Any of You Talk to One Another," based on the fact that actually we do often train our students in silos, as if to believe they can go to a patient who's arrived in hospital as if no one else has ever spoken to them before. And I often say here at the medical school, don't forget when you go in that someone else might have gone in before, and pick that up. And, you know, it's very important that patients tell us, because they come back time and time again to tell us that we are not connected and we fail to connect. And I would totally agree with that. And we have got patient involvement in the CAIPE board.
So I'll maybe ask you to move us on, Liz, if that's okay.
Fantastic. I've stopped and I'll mute now. So I'm passing over to, is Derek here? Doug here?
Yeah, I'm here. Thanks, Liz. And thank you, John. Shall I go on? Well, thank you. Thank you very much for inviting me to speak this evening. I'm Douglas Bilton. I'm the Assistant Director of Standards and Policy for the Professional Standards Authority for Health and Care in the UK. So we're the oversight body, just for those of you who might not know, the oversight body for 10 of the health and care professional regulators. And in doing that, there are a number of statutory functions that we fulfill. We undertake performance reviews of the regulators. We have legal powers to challenge the decisions of fitness to practice hearings, and that we can take various actions if we think that the panels have made a decision that fails to protect the public. We run an accredited registers scheme for registers which are not of those professions and groups which are not regulated by statute, where we issue accreditation to those who meet a set of standards that we set. And finally, and this is where I work and where I come in, I suppose, we do policy work where we're looking to advance regulatory policy. We're looking to build the evidence for how regulation is done and how it can be improved, and we're looking to seek to, through the powers of argument and influence and persuasion, to make that happen, where we don't necessarily have the same legal powers that we do in other areas of our work to undertake processes in particular ways. So what I'm going to do in these few minutes is just say a little about some of the things that we have said from the authority in support of interprofessional education, and in doing so to sort of set out some of the things that are currently happening in the world of the professional regulators that may have some impact and influence on the way that interprofessional education can be advanced in the future. There's an awful lot of change at the moment that's happening and in the air, and I will say a few things about that. But to start with, in one of our publications, I think actually it was in 2017 that we probably first made a public statement in support of the idea of interprofessional education. That was in a sort of substantial publication called Right Touch Reform, in which we set out our ideas at that point about the way that all of the regulatory functions should be modernized and reformed. And that was covering not just quality assurance of education, but also fitness to practice and standards and the register as well. We made a statement there in support of interprofessional education, and I will see if I can summarize it for you. In fact, I may even be able to quote from it. So we said there, I mean, none of the arguments that we put forward would be of any surprise to anybody here, that an increased focus on multi-professional interprofessional education was was desirable, we argued at that point, for all sorts of reasons: meeting new workforce challenges that bridge more than one professional group, growing recognition of the value of instilling a shared understanding and shared values within the healthcare team on how to protect patients and ensure quality care, and many others, multiple and complex challenges facing the health service today. This, of course, was before the pandemic, talking of multiple and complex challenges facing the health service. And just to move on a little to another sort of publication, which I think is significant here, was that we did an analysis, which we actually published only this year, on the regulators' initial responses to the pandemic. And although in doing so, we took a case study approach and worked with the regulators to develop case studies of how they'd responded to the challenges of the pandemic themselves in the way that they carry out their functions. And oh, sorry, I should have said, there's a comment from Wendy. I'm not doing a presentation. I'm very happy to, and I'm not doing a presentation. I'm not using PowerPoint. I'm very happy to circulate some of these references later on if that's helpful to people. We undertook a COVID learning review using case studies that we developed with the regulators to capture for posterity and for future learning how the regulators responded. And everything I'm talking about is available on the website, by the way. And in doing so, made some recommendations generally about how regulation should learn, how regulation might adapt for when any future crises or be that further waves of the pandemic, or be that other kinds of crisis situation might hit in the future. Now, we made some recommendations that we didn't recommend anything specifically to the point of interprofessional education, although we did then talk about, we thought that the experience of the pandemic suggesting it would be worth evaluating the overall balance, structure and length of training, and whether it's right for professions, because we'd seen, of course, as we all did, how different groups were forced to react in different ways very quickly and very flexibly to the situations that arose as a result of the crisis. Coming forward a little further into this year, there was then the government consultation regulating healthcare professionals, protecting the public, which made a range of recommendations about with a general theme of giving regulators greater flexibility, to which we responded substantially. The consultation, when it came out, didn't ask, alas, any questions about interprofessional learning directly. However, it did address interprofessional learning and said it came to the conclusion they didn't propose that a requirement for interprofessional learning should be included in regulators' legislation. Rather, they concluded that this that how they saw interprofessional education being delivered in the future would involve regulators being able to make their own judgments about what was the most appropriate different form of learning for their different professions and their different learning objectives, and gave a range of examples such as academic, lab-based, practical or interprofessional learning where appropriate. So we didn't take from that the government at that point wanted to particularly push interprofessional education. Nevertheless, we did in our response take the opportunity to suggest, for example, that there might be a legislative duty to encourage interprofessional education, which, since we made that response and in the discussions that happened subsequently, that it doesn't seem that idea has been taken up with any keenness. Since the consultation this year, there have been a number of developments which I think in the future are going to have a big influence on the structure of the regulators and how they do their business, how they go about the business of delivering their statutory role. One of those comes from the Health and Care Bill that's currently at the report stage of the third reading, which is the Secretary of State being given new powers to merge or abolish regulators and to deregulate groups. There's also the ongoing discussions coming out of the reform consultation from earlier this year. And in parallel with that, there's also an independent review being taken forward, which is being referred to as a review of the number of regulators. So it would appear that structural changes are likely to happen in the future, which may, if we can assume that that means that there are likely that this may result in the longer term in there being fewer larger regulators, this may be supportive of collaborative or collaboration and greater consistency. Liz's comment earlier, Liz's quotation from an authority publication earlier was very much to this point, that might be conducive to some of the inconsistency and differences of approach that we see now, where those are not necessary for the regulation of different groups being addressed, and the approach is being made more similar and more consistent, possibly. And maybe it would also be conducive to it would be one less barrier, possibly, to the advancement of interprofessional education. I'm not sure I can put it more strongly than that. But there's a lot of, but in short, there is a lot of change, I think, in the pipeline, although it's not possible at the moment to specify exactly what that's going to be. So thank you very much for giving me an opportunity to just share those few comments about where things are, where we stand, and where things are going. Thank you.
Thanks very much, Douglas. It's very helpful to have that overview perspective from your organisation. As I said at the beginning, it's great to see that a number of the individual health and social care regulators are picking up on this agenda, and I will hear from Anne after our break in that regard. And I suppose in the absence of any formal legislatory drive, what we would be hoping for is a continued recommendation to try and encourage that the regulators will continue the conversations that have been taking place, both individually and also through organisations like the Inter-Regulatory Education Group. Do you feel that that's the best way for us to seek to move this agenda forward?
Yes, I would agree with that, absolutely.
Well, I think we had planned a 10-minute break at this point in the programme, Derek, unless there's anything.
I'll just share my screen and then I'll start.
That's great, thank you.
Good evening, everyone. It's so nice to see so many of you here tonight. My name's Anne Trotter. I'm the Assistant Director for Education and Standards at the Nursing and Midwifery Council. I am also a registered children's and adult nurse. I'm just going to cover a few slides looking at it from the prospect of a professional regulator and telling you a little bit about the NMC's journey over the last 6 to 7 years. From an NMC point of view, our purpose and vision, we published our strategy in last year. And here we repurposed ourselves to say that our main role is obviously to regulate, but in doing so, we want to support and influence in as many ways as we can. So who are we and what do we do? So we are the independent regulator for nurses and midwives across the United Kingdom, but we are also now the regulator for a new profession, the nursing associate in England. So that was a whole new thing to start thinking about education standards and proficiency standards in relation to the new profession. We published our registered data last week, the mid-year review, and we now have, as you can see here, 744,929 people on our register, which is the largest register by a long shot of anyone else in the United Kingdom and across Europe. And then obviously our role is to set standards to make sure that people have the necessary knowledge and skill for effective care when they join the register, and looking at not just that knowledge and skill from a skilled practitioner, but the quality of care in relation to respecting and person-centred care needs, preferences and wants from those members of the public. So in terms of what we do by way of regulation. We set standards of proficiency, so that's what people need to know and be able to do in order to practice. We set standards for education and training for universities and their practice placement partners. And we set standards for conduct and behaviour. And alongside that, we will quality assure any programme that we approve. But there's no point, and I've heard people say this, there's no point in us just setting the standards and leaving it at that. We have to be able to say that these standards can land well. And that's why when we began this work some years ago, we undertook an independent evaluation on our standards to see whether they actually had the desired effect, rather than, oh, it's been a while since we changed them, it's time to put out some new ones. So that independent evaluation of our nursing and midwifery standards gave us the foundations about what it was we wanted to do next. But in setting these standards and looking at how they are implemented to support what people need, it's also then giving that understanding about what it is a nurse is and does, what a midwife does as a unique and separate profession, and what the new role in England for nursing associates do. And then people say, well, it would be really helpful if you could give us information on this or that. So again, if there's supporting information, what does that look like, and how would we go about it? But then we can use our influence. And there's lots of organisations that I'm going to go on to talk about that we are involved with. But in doing so, it's that influence in a positive way, not the punitive way that we think, well, if something goes wrong, the NMC will come in and undertake a review, even though they can do that as well. But this is about how we can have a positive influence. So for example, last week when we did publish our register data, it landed on lots of press and media to get a sense of how many nurses and midwives are on the register, but also how that workforce is actually diminishing in size as more people are leaving year on year for the last 5 years. But then what we don't do, and one of the reasons it's important to mention this, is that we do get confused with the Royal College of Nursing and the Royal College of Midwives. So we're not a membership organisation. We are the regulator, and to join that register means that people can professionally practice, rather than people asking, what do I get for my £120? But we don't deliver education, nor do we provide services, nor do we commission education and training. But importantly, and this is where the support and influence comes in, we do work with countries across the United, with all these organisations across the 4 UK countries, to see what it is that's the same and what is different, so our standards do not become a barrier. So when we embarked on our work looking at our standards, we started out with 12 sets of standards, and we thought, well, what do they tell us? What is right about them, and what needs to change and why? And we looked at it through a lens in terms of what do people need from nurses and midwives, not just today, but through to 2030 and beyond. So in asking that question, inevitably what that takes you to is the evidence base. And one of those evidence bases that we always look at is those learnings that come from national inquiries and recommendations for us, perhaps sometimes alongside other regulators as well. And there were 2 seminal national inquiries around the time we kicked off this work. One was the Francis inquiry into Mid Staffordshire, and the other was a report looking into failures of care at Morecambe Bay. And although both these inquiries threw up numerous things and things that needed to change that were equally important, it also made reference to the way in which teams worked together, or largely didn't, the way they communicated with one another, or didn't, and the culture, be it a learning culture, but also it being a culture that promotes change, that promotes sustainability of care and practice, that welcomes and values education. So these 2 things prompted some of the underpinnings of what it was we needed to do and how we would begin that work. So in 2015, we got started, and we said we would embark on a strategic change programme for education. And we had we had three simple objectives. One, we wanted to raise that ambition, not just for the professions, but for the benefit of people who receive care from nurses and midwives, but also the difference that they can make to the practice and to the health and population needs. The safety and quality agenda was very much to the fore back in 2014-15, so we wanted to make sure that our standards made a difference to the quality and safety of that education and training. So many times people would say, we need them to know this and do that, but they come out knowing something else. So what is it that people need from nurses and midwives? Back to that mantra. But we also wanted to make sure that regulation was fit for purpose, that it wasn't a barrier to what an individual was trying to achieve in relation to the care they would provide, and for any service delivery or development. And that has clearly borne out over these last 20 months or so, living through a pandemic, as all the health and care professions have had to learn and adapt to changing circumstances, to changing practices, and to a lack of evidence base, moving towards a developing evidence base. But we also had some things that we knew we wanted to do. We wanted our standards to move from process input to outcome based. So rather thinking about time measures, thinking about the outcome, making sure the language was well understood and clear and not ambiguous. As I said, we wanted to look at what people needed now and towards 2030. So those standards needed to stand that test of time. We wanted an evidence base into why the regulator would need to set the standard in the first place. And as I didn't write this because Douglas was here, but obviously we want to be proportionate in making sure that the regulation and setting of standards by the NMC was right touch. Of course, there's no point in us writing standards and publishing them if they're not measurable or accessible. So they needed to work for the service users, be they students, be they educators in practice, or educators within a university. We wanted to embed equality, diversity, inclusion throughout to recognise the diverse population of the United Kingdom. We also wanted to push as far as we could, and this is where the relevance to tonight comes, what that professionalism is and how working in teams within cultures that are positive cultures, and moving that into not just the regulator telling people how to do things, but to encourage that innovation in education and practice. So that meant deconstructing every set of standard we had and moving into a new way of presenting these standards. So on the right, you will see the standards of proficiency, what people need to know and be able to do for the three professions that we regulate. And included in that is something in relation to post-reg as well. So an example of that would be prescribing practice. And on the left-hand side, we built a new framework for education and training. So I'm just going to walk you through. And what that meant is that we could be consistent from a regulatory point of view, make sure that regardless of the part of the register that we were referring to in the proficiencies, the education and training had a regulatory consistency to it. So what has changed? We developed what we call the educational framework, known as Part 1. And actually, we thought, well, what do we want to do? So this is standards that would apply to nursing and midwifery, regardless of the part of the register, regardless of where the education takes place across the United Kingdom. And we looked at what else was out there. So we've modelled this on the Promoting Excellence framework from the General Medical Council, and we actually seconded General Medical Council staff to support this work. And although we wanted to make sure that the partnership between the university, which we call the Approved Education Institution, and the placement partners was as high as it could be, because within our legislation, the accountable partner is the university. But we wanted to make sure that practice had a part to play, because 50% of the learning takes place in practice. And within these standards, there is clear evidence of what we expect in relation to interprofessional learning and working, and how service users and people in their care are involved in that contribution. We also published new standards for student supervision and assessment. We had legacy standards that had been in place for some time. They were loved and hated in equal measure, and they were very much bound within professional roles. So we wanted to make sure that there was a clarity of what it is to supervise and what it is to assess. We wanted to make sure there was consistency within it, and in line with some of the evidence that the NMC had actually commissioned from its predecessor organisation, we wanted to minimise the opportunity for failing to fail, where people were progressing through their programme of study, and although people felt they weren't quite good enough, no one was making the judgments appropriately. We wanted to improve interprofessional working. So within this, there needed to be that joint working between the university and the practice area, making sure that everyone on our register had a responsibility to supervise students and support them in their educational journey. But what we also explicitly stated was the opportunity for other registered health and care professionals to undertake a practice supervisor role. This was groundbreaking. It's not in any of the other regulator standards. And we thought it was the right thing to do, because so much of the learning does take place between professions, not just within your own professions. We felt it would break down barriers. But in saying that, there has been a little bit of resistance, because you saw from the size of our register, we have more students than any other profession, and people struggle to supervise their own profession students. So some people get paid to supervise students. And so people were looking for payment. People were saying, well, how could we do yours as well as ours? So although we have within our standards enabled this to happen, it doesn't mean that it's been widely accepted across the United Kingdom. But it wasn't just within the education and training standards. Within the proficiency standards, so again, what people need to know and be able to do, here are a couple of examples of how we've embedded interprofessional learning and being able to work within interdisciplinary teams. So demonstrate the knowledge and confidence to contribute effectively and proactively within the team. Demonstrate an understanding of the roles. So often in our evidence and stakeholder engagement, people knew that they worked with different professions, but they didn't always understand what they did. And so it was important to make sure that the right and a most appropriate member of the multidisciplinary team who had the right knowledge and skills at the time that the person needed it was available to make the contributions to others involved in care. Advocating for patients is not just about nurses and midwives carrying out it, but making sure you know who your team is and who it is that you have with you. So Future Nurses, it's called, everything is connected. And alongside that is the programme standards, which reflect the student journey. And the student journey to meet those standards of proficiency require us to see evidence of interdisciplinary working, multi-professional learning, interprofessional education. And the very first programme that sought approval against these new standards was a university who had 9 of the 10 professions within their university being educated with. The one that they did not have commission for was for medicine. And so they took all of their programmes across all the professions and looked at how interprofessional learning could be achieved, not just in line with the new NMC standards, but across the different regulatory groups. And they actually got approval with almost no conditions from the outset. So it's not impossible to do. We went on to do the same with our midwifery standards. So again, here you see some examples of how the proficiency standards, what midwives need to know and be able to do, are embedded. And this was in a direct way in relation to the recommendations coming out of Morecambe Bay and other reports relating to midwifery failures of care. And sometimes some of the recommendations coming to the NMC were making representation that the NMC and the Royal College of Obstetricians and Gynecologists develop education together and support interprofessional learning. Now here you've got a Royal Medical College, you've got a regulator, and you've got something at pre-registration undergraduate level, and you've got something for medicine that takes place after initial registration as a medical practitioner. So it was no easy task to get the wording right and to be enabling and supportive of what interdisciplinary means, how it is to work effectively within a team, and how the education and training through the midwifery programme can achieve this. But we didn't even have this on the horizon when we started doing this work, but introduce a new profession that the NMC was then asked to regulate. And this is a role that sits between the healthcare assistant and the registered nurse, but it is also a progression route for nursing associates who may want to progress to becoming a registered nurse. So again, these standards embed the need to understand the team and to think about what it is that makes an effective team. But we've also got the professional code. This is professional standards of practice and behaviour for nurses, midwives and nursing associates. And although this is the same as other professional codes, for example, good medical practice with the General Medical Council, but again, that notion of working collaboratively from an informed evidence base, not competing, but working together in order to learn with and from one another to meet the needs of people. So I hope what you're seeing from the way I'm describing is that everything we've tried to do is connected, so that nothing is a surprise. There's a consistency across the way in which we regulate. So now we're doing this and we're on our final sets of standards relating to post-registration, things like health visitors, occupational health nurses, school nurses, district nurses. But we have a lot of implementation to support and a lot of quality assurance that we've been working towards. And what we realised quite early on was that this was not about whether interprofessional learning was a good or a bad thing. This was about managing change. So we said quite categorically that we will only approve programmes where the learning culture is ethical, open and honest, is conducive to safe and effective learning, that respects the principles of equality and diversity, and where innovation, interprofessional learning and team working are embedded. So that means through our quality assurance, we are looking for evidence of this when we seek to approve programmes and when we continue to monitor those programmes for nursing, midwifery and nursing associates. We want to see how approved education institutions are working with service providers, so it's not just a one-off for the approval purpose, to continue to demonstrate and promote interprofessional learning and working. But it's not just an institution-based driver. We also wanted to make sure that students played their own part as adult learners. So students, we expect them to be empowered and supported, and who are capable with the learning that they do of working in interprofessional and interagency teams. So this is not about spoon feeding. This is about learners, people aspiring to become nurses, midwives and nursing associates, to work effectively and collaboratively within teams and to seek the education, training and support in order to achieve that. Have we cracked it all? Probably not, if I'm honest. And we've heard from Liz about some of the challenges over the time of CAIPE. And actually we did ask CAIPE to look at our educational framework and the way we were developing things at the time. We've heard from Olle talking about practical issues that get in the way. And that's certainly something that we've seen. So our new standards are certainly an enabler for change. We don't want to put barriers in place. We want to seek assurance that people are able to have the knowledge and skills to do the right things at the point of registration. And one of the things that we heard about is recognizing that the multidisciplinary team will vary, and knowing what it is that people know and do and how they complement one another rather than seeking to compete with one another. Now, we are seeing new and different roles coming to play. Some are referred, I've mentioned the nursing associate, but also hybrid roles. And again, Liz mentioned advanced clinical practice. So advanced clinical practice, the vast majority of those at the moment are nurses. And we are going to be looking at whether we should regulate advanced nurse practice. So there are different people who come to those roles, different people with different knowledge and skills with a different regulator, but are moving into new and different territory all the time. Only today there was the surgical care practitioner curriculum consultation that opened. And again, many nurses undertake and fulfill that role. Douglas talked about regulatory reform. There are opportunities for us there to think about how we do more together across the regulatory landscape. But at the same time, we also need to think about the myths that need to be busted. There are so many times where I've heard the NMC will not allow that, and it's really true. So there is that opportunity to be ambitious, to avoid the logistics. Olle talked about it being practicalities. I would agree with him. I called it logistics. Different regulators not doing the same thing at the same time. Universities saying, well, the timetabling would be really difficult, but actually keep looking for those opportunities for interprofessional learning that supports multidisciplinary working. But we have lived through extraordinary times, and there are pressures on the workforce right now. So we need to think about how interprofessional learning does not get put on the back burner because everyone is tired, because there's other things that they need to do that are more of a priority. Now more than ever, it's the complementary team and the collaboration of all these professionals that are making a difference to the care of people. So it's again about promoting it, thinking about how we do it together. So that's a quick whirlwind tour for you, John, and happy to see if there's any questions.
Well, it has been, and Anne, you've covered a huge amount of material there. I'm just conscious of the time, and I wonder, rather than getting into a very short period now, it might be better if we can hold some comments and questions. There's one or two in the chat, which I'm sure we'll come back to. So this would allow us just to let Alison and Julie finish through the rest of the presentations and then have as much time as possible, if you don't mind.
No problem at all, thanks.
So we'll maybe hand over then to Alison, I think, first, and then Julie.
It's actually me, John.
Sorry, Julie.
I'm kicking off, and then it's Alison. I'll just see if I can get my slides going. And where are we? Share. I hope you're now seeing it in designer view. Let's go from, there we go.
Yep, fine.
Excellent, thank you. Hello everyone. Yes, Alison and I are doing a bit of a double act today. Alison and I are both members of Cardiff University, and we work for a research group called CureMed, but we're representing a much bigger team than that, which also includes, of course, Derek and John. And we've been interested in studying mostly dental and dental and medical education over the last 10 or more years together. And today I wanted to talk to you a little bit about what we have learned and some of the things, some of the challenges which we have identified. Now, I have to say, we didn't actually start out to be interprofessional education researchers. We actually were quite interested in monoprofessional educator development. But actually, over the years, we've discovered that interprofessional education is actually the elephant in the room, and that much of what the individual professions want to achieve is not really practical or possible unless we consider interprofessional education. So we want to throw down 4 big challenges that we have identified. And we particularly want to talk about this in relation to the interprofessional education workforce, which we think is actually a major unrealized asset, if you like. Sorry, excuse me. And we want to talk about some of the evidence that underpins all of this. So to begin with, I think the literature is pretty good on identifying what a good interprofessional clinical team looks like. And an awful lot of the standards around interprofessional education actually focus on the outcomes that are desirable from teaching an interprofessional clinical team. So here are some of the ideas around what makes a good interprofessional clinical team. We also have a pretty good idea of what a good generic healthcare educator looks like, thanks partly to some of the work that our group has been doing on a project which we call the HEVAS study, where we were looking specifically at the characteristics, qualities and attitudes of all healthcare professionals, a generic statement of that. Alison will talk about that a bit more in a minute. But we don't really know what a good interprofessional educator looks like. And that's why I picked up rather earlier on Ole's point about how humility is important. Certainly, we know that you need to be able to move beyond your own disciplinary boundaries to work together effectively as an interprofessional educator. We also believe that it involves an ability to achieve a new kind of social identity, which is that of healthcare educator, interprofessional educator, rather than, say, dental educator or nurse educator. We are certain that there are specialist and advanced skills involved. There's very little doubt about that. But again, we haven't identified what those are. And of course, this is a future direction for some of our research. But how is it that we can be reasonably confident in saying that it's difficult to be an interprofessional educator? Well, this is a bit of a cat's cradle, but it's supposed to conceptualize some of the challenges that interprofessional educators face. Now, normally in regular education, especially as it's described in the regulatory and academic literature, the model that's understood is an educator in group A educating a learner in group A. It's dead straightforward. That educator has learned to teach within their own profession, and they know how to speak to a learner from that profession. They understand the curriculum, they understand the clinical practice, they are very confident, and it's easier for them to develop a relationship with that learner. However, in an interprofessional setting, where you might have 3 different educators from 3 different professions, say here A, B, and C, nursing, dentistry, and I don't know, pharmacy. You may also have in the room 3 learners from different groups. So you may well have your nurse and your pharmacist, but you may also have, say, a medical student present. That multiplies the complexity of the teaching encounter dramatically, because now you've got a kind of formal educational communication going on between unmatched professions. That's to say, educator from profession C is somehow trying to work with learner from group B and group D and group A, and they don't share a professional background with them. That can be problematic, because the important thing that educators need more than anything is authenticity and credibility among their students. And so it's an additional challenge for an interprofessional educator when you're working in teams with whom you don't share a professional background to teach people with whom you don't share a professional background. And finally, then, of course, there's the informal communication. And again, one challenge that's not often understood is the role of the teacher, the educator, in facilitating conversations between the learners. And again, if you don't share a professional background with those learners, it can be much more difficult. So one of the chief challenges that Olle again alluded to earlier is that it's very difficult. Social identity theory tells us that yes, as a student, you are learning to join a particular profession, a particular clinical profession. So we know that it's difficult to go from school student to graduate nurse or graduate physio. But then we've also realized that it's very difficult to get from a nurse or doctor to an educator. And some of the work that we've done suggests that it's actually a very complex process, that you don't just evolve into an educator, that it actually involves a degree of choice. And we have based it a bit on the work of Hobson and colleagues in transition theory, where he suggests that there's almost a grief reaction. You have to leave one identity behind in order to adapt to a new one. So you start off in your new role as a newly graduated clinician, and it's all very exciting and you're enjoying it, but it's up and down, you know. There's a lovely honeymoon period where everything seems to be going well and you feel comfortable. After the initial panic, you've settled down into the job. But slowly, and this may be a long process or a very short process, you come to the conclusion that actually it's possibly time to move on, perhaps to take on the next job, to move to the next role. Now, for many people, that's an increasing feeling that perhaps they ought to be getting more involved in education. If that is the case, then there will come a point where they are so torn between their clinical and educational work that they have to make a decision. Do I go on and become a fully fledged healthcare educator within my profession? Or do I do something else? Do I leave that behind and go and find something else to do? I can carry on in my primary profession, of course, but that would involve me also making a change. If you choose to take on this new role, you will eventually arrive at a modified identity, such as, for example, a medical or nursing school lecturer, a preceptor within your discipline. So what happens next? Well, we hypothesize that actually to become an interprofessional educator involves a voyage nearly as difficult as that one. You started out with your primary professional identity. You've arrived in your role as an educator within that profession, as a nurse educator or a doctor educator. But gradually you realize that actually what you want to do is interprofessional educator. And that requires you to adopt a new identity and a new set of skills and to adapt again. So there is a double transition. And as you can see from the dotted lines at the bottom, the potential for people to fall out of the system and just go and do something less difficult instead is very high. Now I'm going to hand over to Alison now, who'll carry on with the rest of our challenges. Thank you for my part.
Yes, thank you, Julie. And if challenge one wasn't enough in terms of that identity, the dual identity transitions, I'm going to briefly outline a few other challenges. So challenge two, we have identified as the standards training and appraisal for educators being set by single professions. Now, Julie did refer to our study earlier, the HEVAS study, where we were looking at healthcare educators' values and activities. And we analysed 48 standards documents, which were detailing the standards for educators across 25 professions. We used this analysis in various consensus building methods, including a nominal group activity and a Delphi study. And from this, we identified 9 core values and 25 activities that were shared by educators across healthcare professions. And we grouped those into 4 domains, the activities into 4 domains: preparation for teaching, teaching and supporting learning, learner progression, and quality. Now, the results of the HEVAS study provides a consensus statement of the basic values and activities expected of all healthcare educators across different professions. Next slide, please, Julie. But despite our careful scrutiny of 48 standards documents, we found no multi-professional educator standards at that time, no interprofessional educator standards, indeed, very little attention given to interprofessional education, and no recommendations related to specialist training for the interprofessional educator workforce. Next slide, please, Julie. So that was a brief outline of challenge 2. Moving on to channel 3. And here we turn to our study of the regulatory literature on interprofessional education, where we found that to be largely silent about interprofessional educators. So one conclusion from our literature review, which we undertook for the PSA, the Professional Standards Authority, and as we've heard from Douglas, that's the body that oversees the regulation of all regulated healthcare professionals. So one of our findings was that a more common approach to regulation seems to be thwarted by a number of things, including the hierarchies that are in existence in and amongst healthcare professions and professionals. And the lack of a common approach is a matter of concern, because if we think of our profession, whichever that is, trusts that those from other professions have the knowledge and skills appropriate to teach our learners, then the concern is that that may not always be the case. So that cross-professional trust is something that is assumed and may not always be the case. So we suggest that regulators have an important role to play in setting policy agendas that can promote interprofessional education. Next slide, please, Julie. Challenge 4. So from all of this, it's clear that we need something of a collaborative approach to the recognition, training, support and career development of interprofessional educators. But our question is, who's going to drive this? It's a high-level challenge to bring together multiple different players. The professions that need to address things like hierarchies and tribalism, the regulators to develop common approaches, perhaps, the employers to give greater attention to interprofessional educators, the education and training bodies to resource training and support and offer support for interprofessional educators. There's a role for researchers too, in terms of undertaking high quality, more and high quality interprofessional education research. And we'd add on the interprofessional educators themselves, perhaps through coming together in perhaps in greater numbers as part of learned societies such as CAIPE, such as the Academy here today. And perhaps if they are able to come together in greater numbers, then within a learned society, there's maybe the capacity to push for greater resources, for career pathways, for institutional support, and indeed for the development of interprofessional educator leaders. And we might also add in that a role too for patients and patient representative groups. So challenge 4 can be seen as something of a call for further action. Next slide, please, Julie.
So
I think we go back one, can we, Julie? There should be a summary.
there we go.
One more, back one more.
That's it. Nope, that was
Okay. Oh, there
Sorry.
it is. Thank you, Julie. So by way of a summary then, it's not to say that, I think it would be misplaced to say that there hasn't been any progress on these challenges, but we would identify that there certainly are 4 challenges that have arisen from the work that we've done in this area. The first is that becoming an interprofessional educator requires that dual change in professional identity. The second is that currently educator standards are set by single professions and training occurs in those monodisciplines. The third, that the regulatory literature is pretty silent about interprofessional educators. And the fourth, that the interprofessional educators, to be recognised, trained and supported and developed, needs collaboration across professions, across regulators, employers, education and training bodies, researchers, the interprofessional educators themselves, and we could add in patients to that. Next slide, please, Julie. I just want to end with a short quote there. By way of final word then, we know that there's a lot of goodwill about interprofessional education, but we would say that we need more than just good intentions and piecemeal development to bring about real progress. Thank you.
Thanks very much. John, I was going to invite questions at this point, but I'm wondering if I should just nip on to my the final part about the Academy standards, and we can take general questions at the end in order to save some time. So I'm now putting on my different hat. So I should probably just do a quick, swirl around and come out dressed like Wonder Woman or something, because tonight I'm here for this part of the evening just to represent the Academy of Medical Educators, for which I'm the Vice Chair of their council. And so I'm speaking on behalf of the Academy now rather than on behalf of our research group. Of course, the Academy of Medical Educators is behind tonight's talk. And I think that this is a topic that is very dear to the Academy of Medical Educators' heart, partly because we have already been here before when it came to the question of the recognition and training of medical educators. And we have seen over the years that there have been a number of things that have actually very much helped to advance the position of medical educators that may well be proved to be lessons learned for other educators as well. So what we suggest is that healthcare educators working in interprofessional education actually need something more. They need recognition and career development as a distinct professional community. Now, the Academy of Medical Educators was set up in 2009 to advance medical education for the benefit of the public. And its first job was to develop a professional standards framework and qualification system for medical educators. And that includes veterinary and dental and now physician associate educators. Because without the professional standards framework, we weren't able to recognize the skills, talents, contributions and achievements of medical educators. And we realized that this was just not happening. So it's within our articles of association that this is what we need to do. So we did it. We set up a professional standards framework and qualification system. And this is roughly what it looks like. It's got a set of core values in the center. And around it are the areas of activity that a good educator in medical, dental, veterinary and PA education should do. I should say that the various domains there, 1, 2, 3, 4 and 5, are areas of activity, and we have them graded into levels of 4 levels of achievement. So it's used to recognize membership, fellowship and principal fellowship, and people submit their portfolios of achievements to us, and they're awarded membership, fellowship or principal fellowship as they progress through their careers. So it's a grand opportunity to affirm our contract with society, first of all, by showing what it is that we as educators know, do and believe. And secondly, it's a way of reassuring the public that our members, fellows and principal fellows are working to a code of practice and a set of standards across the piece. Oh, I apologise. Something's happened very strange there. My slides are obviously misbehaving tonight. So the Academy of Professional Standards, they recognise the educators as dentists, vets, doctors and physician associates, these educators. And we are defined not by who we are, because we're a very multi-professional group, but by who we teach. So we teach those 4 groups. I'm really pleased to announce tonight that we have a new set of professional standards. It's been a little while in the coming, but this is an advance notice that we do now have a 4th edition. And it's changed in terms of we have added the 4th level of achievements in order to be able to award higher levels of membership, principal fellowship. And also it has been strengthened in a number of ways. And I'm really pleased that it has added in a few phrases from the most recent edition that actually reaffirm the commitment of at least medical educators to inter, trans and multi-professional education and learning with, from and about other professionals. The CAIPE people will recognise that phrase there, to improve collaborative care. And it's important, we have added in that one of our key values is respect for colleagues as demonstrated by our due consideration for our colleagues within the interprofessional team. If you're interested to know more about the Academy and its professional standards, there's the website. But that was just a sort of closing bit about the Academy. And again, I'd love to thank them for putting on this event. So I'll pass back now to Derek and to John, who are the chairs of this evening, for the next part of the session.
Well, Derek's going to take us through the limited time that we have left. But, if I could just say to Tony, there were some references at the end of Julie and Alison's presentation, which I don't think we had time to leave on the screen for a moment if people wanted to pick those up. Although I know that this is being recorded and that the slides can be made available subsequently. But we might just put the reference slide up while Derek deals with the discussion. Thanks.
We'll be more than happy to do that. But yes, we'll be passing the slides around if anybody wants them.
Thank you. I hope you can hear me. Okay. We've covered a lot of ground in the last 2 hours, and it's going to be very difficult to try and summarize that in the next a minute or two. However, one of the highlight areas for us to think about is about the creativity that we are going to try and display in driving forward this agenda. A very big question, which I think Olle started this out with in a way, is the cultural aspect, which is still deeply embedded and not a major driver to taking this agenda forward, and how we might actually change the culture. Looking through the chat, people have been concerned about the economics of interprofessional. Like, is it cost effective? Is it not cost effective? I think we're all clearly aware that if you put 2 different professions in a room to teach them, that's economics, it's not interprofessional. So much of it is, should we just put 2 lots in the room? And the answer is no to that at all. One of the questions I wanted to put, if there is time for any of the panel members to answer or just give an opinion on, really, is what is the next big step? I mean, COVID has focused us more than anything on the role of the team, the interprofessional, the use of students, all hands to the pumps, as it were. But what's the big leap? If CAIPE's been going for 60 years and it's made progress, clearly, I'm not saying, but is there a big step? And if there is, what is it? Who is it? Is it the regulators really getting behind this agenda? Or is it somebody else? I've just opened that out in the last few minutes.
Derek, I'll just say a few things. I think it's a massive question, maybe starting from a lower platform than where we are, in that there is a tremendous amount to celebrate. Some people thinking medicine's been left behind, but not really. There's a system change coming in the new white paper, and a better alignment of understanding what this means should come to the regulators now. They're probably lagging behind. There is phenomenal interest in the push of the moment, which must come from practice systems and educational systems aligning better than they do right now. And that needs political understanding and will. As for the work of educators, there are many published books around about that. Yvonne Steinhardt has chapters on faculty development for interprofessional education, and I commend the work going on by the Association of Medical Educators, because some of the poorly delivered interprofessional education can often fall at the feet of those who are ill-equipped to deliver it properly and well. And that doesn't do us any favours, sadly, in the end. So I push for understanding how we can ensure that no one gets a master's in clinical education without having good interprofessional skills would be a good place to also go. So that's just a few thoughts from me.
Other of our speakers want to just come in at this late hour and say what the next big step for them would be if they had a choice. I mean, I know Julie and Alison, you put up a list of people. I think there were 6 on your slide there. Who should step up first?
Eric, I think there is literature. I mentioned it briefly in the introduction internationally, which is worth us referring to, both in North America, surprisingly perhaps, because they don't tend always to be in the forefront of these developments. But the National Academy of Medicine has published some quite useful material. But I think from New Zealand particularly, there are a number of publications, some of them medical teacher, about how getting the groups together, this collaboration between the educators, the workforce planners, and the regulators, and not groups who naturally tend to talk a lot to each other, I have to say, but there are individual roles for them which can be complemented and which will be much more effective if some way can be found to open lines of communication between those groups. And I don't see that happening in the UK or Ireland at this point in time. So whether we as a group following this symposium can try to catch the attention of some of those groups and perhaps help them to understand that in the new regulatory framework that is going to be introduced, there would be ideal opportunities for some of this to actually be implemented at that time, not necessarily by forceful legislation, as Douglas has pointed out, but by encouragement. And I think that in that, there are a number of bodies who could play a very important role.
Thank you, John. I suppose I'm just trying to reflect a sense of frustration of how long it takes us to move some of this agenda forward when we clearly, and we are a self-picked audience, but we clearly feel so strongly about the whole issue.
As I hope we've sort of made clear in our recent presentation, that we would still be arguing that it's going to take a bit of bolshiness on the part of the interprofessional educators themselves. And I think that's more or less a polite way of saying what you have just been saying, John, that we need to be talking much more to those people who are mandating interprofessional education without providing the resources and the training to develop the educational workforce that is actually going to be delivering it. And I think too often the educators are the elephant in the room, or you know, where they are not seen as absolutely essential to the process, that somehow education, because everybody can do it, it's easy to do, and interprofessional education, well, that's just getting people into a room to talk together. And I really think it's a question partly to do with the status of interprofessional educators. They are not seen as the very highly skilled, exceptionally dedicated people that they actually are, in my view. Andy, I see you've raised your hand.
Yeah, just very briefly, I just feel like maybe you say a word for the poor educators and the education leads. I think that we may find that if we approach the education leads in all professions, my own background is in medicine, and I was head of an undergraduate medical program, is that you might say, these people might say to us, yes, we think it's a great idea, but you know, I'm up till 10 o'clock at night doing my emails every night now. I can't possibly take on another big project. And I think that my colleagues in other people doing the same job as me in other professions within the university might say the same. So there may be a lot of willingness, but a capacity issue.
I'm sure that's true, and there are some people in the chat also saying that we're time limited during the working day, but part of this is to make not only our job easier, but it's also to improve patient care. You know, and that's, we haven't maybe said enough about that aspect of the interprofessional educator's role this afternoon than we might have done. But again, you know, clearly very important as we move more towards more generalist training, which talks, I think, very specifically to teamwork and educators together and learning together going forward.
If we could end, well, I'm not talking about drawing it to a close, but if we are moving towards ending on a positive note, given all of the developments in the different roles, that does draw attention to the importance of teamwork and that whole skill mix and working with your colleagues, that you could identify this as it being very timely to push this agenda forward in terms of interprofessional collaboration, interprofessional education underpinning that. So the new and diverse roles that are being introduced really puts this high up on the agenda. So wouldn't it be good if we could find a way of capitalizing that in some way and using it to draw greater attention to the importance of interprofessional education and the educators within that?
Yes, and that's a great way to end, I think, this. I'm clear that we are losing participants as the time goes on and time is there. I think we do need to come back and follow up with this. We've had a very good audience and widespread involvement today, and it would be sad not to build on this going forward. So I would hope that we would be able to get back to you all with a follow-up, not only just on the work that's ongoing, but the work that individual organisations who are represented here today are doing with regard to this agenda. So if a very big thank you to all our speakers, obviously. Are there any final words from anyone? John?
I think I've said enough. Thanks. Great evening. Very important.
Excellent. All right. Well, thank you everyone for your time, and we will come back. This is not going away, as we well know. So once again, thank you. and have a good evening.